Good afternoon. My name is Kyle, and I will be your conference operator today. At this time, I would like to welcome everyone to the QIO National LAN Event Conference Call. All lines will be placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question, simply press star, then the number 1 on your telephone keypad. To withdraw your question, press the pound key. Thank you. Ms. Kaylee Doyle, you may begin your conference.
Hi, and good afternoon. Thank you for joining us for the National Learning in Action Network, or LAN event today. We're happy to have you all with us today as we discuss this important topic of antibiotic stewardship. My name is Kaylee Doyle with Telegen and the Quality Innovation Network National Coordinating Center, and I'll be serving as the facilitator for today's event. A few reminders and housekeeping items before we get started. Thanks for joining us in the WebEx Event Center. In order to access the WebEx, you will need to access your registration confirmation email and your unique registration ID to log in. My colleague, Melanie Wasserman, will be monitoring our WebEx chat board today, and we encourage you to use the chat to share, ask questions, and participate in today's discussion. Today's slides and resources can be found on the QIOprogram.org website under the Events tab, and a recording of the session will be posted when it becomes available. So let's start by reviewing today's agenda. First, I'll be going over the continuing education details, then I'll introduce you to each of our speakers today, and we'll hear our speaker presentations. Following the presentations, there will be a facilitated discussion where questions from the audience can be addressed. If we do not get to your question right away, know that we're compiling them and we'll attempt to address as many questions as possible during the discussion portion of the call. And then finally, I'll wrap up with a reminder to complete our post-event assessment and a plug for our upcoming calls. So I want to take just a minute to remind our participants about the purpose of this important series of national learning and sharing events. Without reading all the content on the slide, I just want to mention a few high points. The audience for these events is broad and inclusive of a variety of healthcare providers, partners, and patients. The purpose of these webinars is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. We ask that participants think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your teams and organizations. And finally, we're always open to new ideas and suggestions for topics to bring to this audience, so please feel free to send your ideas through the chat or through the post-event assessment. We're excited to be offering continuing education credits to all attendees for participating in the session. We offer credits to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer credits of attendance. Should you have requests for additional accreditation types, we welcome those suggestions as well, again through the chat or through the post-event assessment. In order to apply for the continuing education credit, you must do the following things. Attend this entire event, and then complete the post-event assessment upon exiting this WebEx session. And note that the CE evaluation will only be accessed through the application site hyperlink that comes up at the end of the post-event assessment. For any technical assistance related to the CE process, please email Stacey Davis, and her email will be posted in chat. So this slide is a disclaimer from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants, and you can reference this slide for the full CE statement. This activity also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians. And this slide has the accreditation statements for those entities. And then another disclaimer, we'd like to report that the planners and faculty for this event, CRW and Associates, and Telegen, do not have any financial relationships to disclose, nor was any commercial support received for this activity. So then finally, here are disclosures of financial relationships. So we'd like to get an idea of who is in the room or on the phone with us today. So we're hoping you can chat in what organization you are representing and attending on the call. So please let us know in chat where you are working. And then while you're entering your introduction, I'll review the session goals today. So by the end of today's call, you'll be able to discuss how the core elements of outpatient antibiotic stewardship improve antibiotic use and outcomes, explain the importance of improving communication between nursing homes, emergency departments, and acute care hospitals to decrease inappropriate antibiotic prescribing, and develop awareness of emerging stewardship efforts and resources. Welcome, everybody. Thanks for introducing yourselves in the chat. I've been trying to look through while I was reading, but it looks like we have quite a few QuinkQIOs, hospitals, a variety of different organizations. So welcome and thanks for joining our session today. It's now my pleasure to introduce you to our first speaker, Dr. Patrick Gee. Dr. Gee is a patient advocate and will frame our session with a personal story. Thank you for being here with us today, Patrick. The floor is yours.
Thank you, and I want to say good afternoon to everybody that is in attendance. Before we get started, I just want to say that my education is in justice law and criminology, so I'm by no means a physician, but on today I'm just going to share my lived experience through kidney disease and the comorbidities that goes along with that, and the antibiotic stewardship also with that. When I think about stewardship, I think about management of care, and this starts with patient engagement. And one of the things that's most important with patient engagement is the relationship that a patient has with their care provider. So let me begin with my journey. In April of 2013, I was told by my endocrinologist that I had 35% kidney function. So at that time, they referred me to a nephrologist, and it wasn't until November of 2013 that I began peritoneal dialysis. So you can go to the next slide. This is myself doing peritoneal dialysis. So as you can see, I'm holding a sign where I did 5 exchanges a day, 7 days a week, on an average of 10.5 hours a day. You multiply that by 7, so that was 73.5 hours of dialysis that I did per week, which came to 294 hours of dialysis a month. If you multiply that by 12, that comes to 3,528 hours of dialysis. And I stayed on dialysis for 4 years. So if you multiply that by 4 years, I did 14,112 hours of peritoneal dialysis. While I was on dialysis, I was prescribed an antibiotic to only use if I suffered with peritonitis, which would be an infection in my peritoneum. So it was one time where they thought that I had peritonitis. Come to find out that I didn't have peritonitis, but my gallbladder exploded. So when I was in the hospital, I was being treated with 4 different antibiotics all at the same time, to the point that I was on the antibiotic for like 5 days, and they was like, well, they saw no changes. So they removed my peritoneal catheter. The problem was I was still in excruciating pain, and they found out that my gallbladder had exploded. So in hindsight, they removed my catheter for nothing. So I had to have another surgery to kind of clean up the stuff the gallbladder that had literally exploded. So in between that time, I did in-center hemodialysis while waiting to heal so I could go back to get my peritoneal catheter put back in. Once I got it back in, I went back on peritoneal dialysis up until April of 2017. At that particular time, I received a kidney transplant. But when I woke up, the kidney didn't. So 5 days after my transplant, I was told that I had a blood clot in my neck, so I had to have another surgery. 3 days after that surgery, I was bleeding internally, so I had to have a third surgery. They installed a J-tube in me for me to drain it. I kept that J-tube in me for approximately 17 days, and then I had to have a fourth surgery to remove the J-tube so that they could create a peritoneal window for me to drain internally. Now, mind you, my kidney is still not working at this time. So after 33 days in the hospital, a total of 4 surgeries, I was released to go home, but my kidney is not working. My kidney literally didn't work until the 47th day, so if you could advance to the next slide. The next slide, this is my first day at home, and this is my wound. Because I had so many surgeries, they decided that I needed to heal naturally. So because I had an open wound, I'm now on a different type of antibiotic. Because not only with my wound being open, but I also had a stent inside my bladder, keeping my bladder open. So it was necessary for me to continue on an antibiotic regimen so that I wouldn't get infections until my kidney actually started working. So my kidney didn't kick in until the 47th day, but the stent still stayed in for another month afterwards. So literally, I was on an antibiotic regimen probably for about 90 days before I was taken off of the stent removed, and I had a bit of normalcy. I wasn't on antibiotics again until December of last year, where I acquired pneumonia. Now, of course, with any type of organ transplant, you have a compromised immune system. So, of course, I couldn't be prescribed any type of antibiotic because I would need to be prescribed an antibiotic that will not harm my kidney. One of the interesting things was when I went to an emergency care unit, an emergency outpatient care unit, they prescribed me one type of antibiotic. When I notified my transplant center, they told me to discontinue with that particular antibiotic, and they prescribed something else. I stayed on that antibiotic that they prescribed for about 14 days. What was really interesting about that is it wasn't until the 14th day when I was down to the last pill that I found out that the FDA and the CDC had recalled this particular antibiotic because it caused tears in the heart valve. So, of course, I was concerned, and after doing some investigation, also found out that this particular type of antibiotics will actually do more harm than good for my kidneys. And when I called my transplant team, it was interesting that they told me that, yes, this would do harm if I stayed on it long term, meaning anything over the 14-day period. But for me to be able to combat the pneumonia, especially with having a compromised immune system, it was beneficial. Plus, they were monitoring my situation. So, in closing, I want to share 4 things that I learned as a patient dealing with the management of antibiotics. One of the things I had to learn is that antibiotics don't work for everything. Antibiotics that fight bacterial infections don't necessarily work for viral infections. So that was really interesting, and that was key to their patients listening, to make sure that you always ask those that are prescribing any type of antibiotic to you, the purpose for it, why this particular kind, do they know if it will mess with any type of medication, cause any side effects, and if you really need it. The second thing that I've learned is if you take antibiotics unnecessarily, they may do more harm than good. With nowadays, with antibiotics being put into foods such as chicken and stuff like that, our bodies tend to build up resistance towards antibiotics. So you just don't want to self-diagnose yourself, or if you have a cold or something, you think, well, let me take an antibiotic and I can cure myself. You should really consult a physician anytime you do this and get away from the perception that, well, I know more than the physicians. Let me just go ahead and take this medication on my own. The third thing that I found out was that antibiotics are not a one-size-fits-all. Because if you take as an example an antibiotic that works for urinary tract infection, it won't help you with strep throat. So we need to be very careful with that. And the fourth thing that I learned is that you shouldn't save antibiotics. One of the things that I just found out recently, again, with me living with a compromised immune system, is when I go to the dentist for my teeth to be cleaned, they prescribe an antibiotic. And they will tell me, with me going once every 6 months, they will say, well, we prescribed you 10 antibiotics, and you just make sure you take one an hour before you come. And I had to tell them, I said, look, you know that I have a kidney transplant, and I don't want to be using anything that's out of date because my concern is it may not work. So what I got them to do is to prescribe me a new prescription before I go to my visit so that I would have a fresh prescription knowing that the antibiotic would work. So in closing, I just want to encourage any patients that may be listening right now to really be your own advocate, to really engage with your providers and your care team into learning about the antibiotics that are being prescribed to you and the side effects. Does it work good with the medications that you're on? And just take control of your health care. For the physicians that are out here, as a patient, if you could explain to me the necessity of using the antibiotic, is it necessary for me to use an antibiotic? Will I heal on my own? And the purpose of the antibiotic, it would just help a long way in not only kind of calming us, but reassuring that, there's trust that can be built up in the correspondence of the engagement. So, again, thank you for this opportunity for me to share my story. And if there's any questions, just feel free to ask. Thank you.
Thank you so much, Patrick, for being willing to share your story with us and what you learned from your experience, and reminding everyone here why this topic and this work of antibiotic stewardship is so important. So thank you for being here. And anyone with questions for Patrick, we can take those at the end of the call after our speaker presentation. So it's now my pleasure to introduce our first speaker from the Centers for Disease Control and Prevention. Dr. Catherine Fleming-Dutra is Deputy Director of the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion at the CDC. Dr. Fleming-Dutra is a trained pediatrician and leads the outpatient antibiotic stewardship efforts at the CDC. Dr. Fleming-Dutra, we appreciate you being here today, and the floor is yours.
Thank you very much. And thank you so much to Patrick for sharing that really powerful story. And it's such a great introduction always a great reminder for us to remember to keep the patient at the heart of all that we, our patients at the heart of all that we do. And I think Patrick's story really helps us remember, I know you all know this, but just really brings home that antibiotics really are life-saving medicines. In the roughly 80 years since penicillin was introduced to the market, millions of lives have been saved. And I think what's also really powerful about your story, Patrick, is that they help us remind us that antibiotics underpin modern medicine as we know it. They make it safer for us to do surgeries, to perform procedures like dialysis, to perform organ transplants, and to treat cancer with chemotherapies, because we can prevent and treat bacterial infections that happen in our vulnerable patients. And that is why antibiotic resistance is a pressing global public health threat. And CDC estimates that 2 million illnesses and 23,000 deaths occur each year in the United States from antibiotic-resistant infections. And antibiotic-resistant infections are costly, leading to an estimated $20 billion in excess direct health care costs. And for those patients who survive antibiotic-resistant infections, these infections can lead to significant morbidity. And CDC estimates that the additional annual cost of lost productivity is greater than $35 billion. And CDC's response to combating antibiotic resistance is multifaceted, and antibiotic stewardship is a key strategy in that response. Combating antibiotic resistance starts by preventing infections in the first place, with vaccines, with infection control, and all the things that we do to keep people healthy. And then CDC also maintains surveillance to detect antibiotic-resistant pathogens that are considered threats and respond to and contain those threats when and where they emerge. And, of course, we work to improve antibiotic use. And I work in CDC's Office of Antibiotic Stewardship, and our mission is to optimize antibiotic use in human healthcare to combat antibiotic resistance and improve healthcare quality and patient safety. And I just want to point out that the heart of all that we do is about patient safety. And I lead the outpatient stewardship efforts in our office. And we know that there are significant opportunities to improve antibiotic use in the outpatient setting. We estimate that at least 30% of antibiotic prescriptions written in U.S. doctors' offices and emergency departments are unnecessary, meaning that no antibiotic was needed at all. And many of these prescriptions are for conditions like the common cold or acute bronchitis, where antibiotics do not help and they can cause harm to the patient. And antibiotic adverse events can be severe, including allergic reactions. This is a picture of a child experiencing an allergic reaction with hives, and allergic reactions, as well as other adverse events, can often require emergency care. And antibiotic adverse events can lead to emergency department or ED visits. Roughly 1 in 1,000 antibiotic prescriptions leads to an ED visit for an adverse event, which results in an estimated 200,000 ED visits per year in the United States. And when a patient needs antibiotics, we accept these risks, but we should not accept these risks when the patient does not need an antibiotic. And these estimates do not include Clostridioides difficile infection, formerly called Clostridium difficile. C. difficile infection is a serious consequence of antibiotic use, and CDC estimates that 453,000 infections and 15,000 deaths occur from C. difficile in the U.S. annually. Of these, 35% are community-associated, meaning that the patient did not have an overnight stay in a hospital or long-term care facility. And the average cost of inpatient care for community-onset C. difficile infection is about $20,000. And these infections can become recurrent, leading to even more burden to the patient and to higher costs. So C. difficile is a costly and potentially fatal consequence of antibiotic use, and thus prevention of C. difficile infection is key. To help facilitate the uptake of antibiotic stewardship in outpatient settings, CDC developed the core elements of outpatient antibiotic stewardship to provide a framework for implementing antibiotic stewardship in outpatient settings. Under each core element, we included evidence-based interventions that clinicians and outpatient facilities can do, but at the time we published this, we hadn't actually evaluated them together as a bundle. And so now I want to talk about some preliminary data from a study in which we worked with the University of Utah and the VA to do that. So in this project, 14 Veterans Health Administration or VHA clinics implemented the core elements of outpatient stewardship to improve antibiotic use for acute respiratory infections, or ARIs. The data are from 2014 to 2018. They had a staggered rollout of their intervention with 4 sites starting in 2015 and 10 in 2017. And they included over 29,000 ARI visits in the pre-intervention period and over 8,000 post-intervention in their analyses. And this work was presented by Carl Medeiros-Kelly and colleagues at ID Week in 2018. So what they do, for the commitment core element, they engage facility leadership and VA stewards, and they recruited site champions at all their enrolled clinics. These champions were physicians, nurse practitioners, or physician assistants at each clinic who led stewardship within the clinic and helped disseminate the stewardship messages. For Action for Policy and Practice, the site champions or antibiotic stewards from the local VA hospital conducted academic detailing, which means an in-person active educational session that's one-on-one with providers. They were trained on how to conduct academic detailing, and detailing focused on appropriate antibiotic use for acute respiratory infections. They also had kickoff presentations for the interventions and acute respiratory infection-specific order sets in their electronic health records. For tracking and reporting, audit and feedback reports were given at baseline and every 2 to 3 months. So here's an example of a feedback report given to a provider. These are pretty complicated, but the site champion was trained to give this feedback. And the feedback included individual provider and clinic level antibiotic prescribing for acute respiratory infections. And providers were provided data comparing them to top performing providers, meaning those prescribing antibiotics most in line with guideline recommendations. And then dashboards were created that allowed providers, site champions, and stewards to track antibiotic prescribing. And for education expertise, they produced educational materials for providers and patients about appropriate antibiotic use for acute respiratory infections. So what did they find? They found that these interventions resulted in decreases in antibiotic prescription rates for all acute respiratory infections. This graph shows the prevalence rate ratio and 95% confidence intervals for antibiotic prescribing for ARI post versus pre-intervention. And you can see that they had significant reductions in antibiotic prescribing for bronchitis, URIs, pharyngitis, and sinusitis. And when they rolled it all up together, they saw reductions in antibiotic prescribing for all uncomplicated ARIs. So these interventions reduced antibiotic prescribing for acute respiratory infections, which is great, but we also wanted to know if it was safe. And so the VA was also able to track impact on balancing measures to ensure the safety of these interventions. So they found that the interventions were safe as there were no differences in revisits for acute respiratory infections or hospitalizations within 30 days. You can see that in this graph, which shows the risk ratios and 95% confidence intervals for 30-day revisits for ARIs and 30-day hospitalizations in the post-intervention period compared to the pre-intervention period. So in summary, the VA was able to implement the core elements as a bundle in these 14 clinics, and they found that the core elements of outpatient antibiotic stewardship can effectively and safely reduce antibiotic use for acute respiratory infections. So with that, thank you, and please save the date for U.S. Antibiotics Awareness Week, which will be November 18th through the 24th this year. And I'll turn it back to Kaylee.
Thank you so much, Dr. Fleming-Dutra. Great information and great example of how the core elements and the implementation of core elements really do work. And I hope that people on the call can use the example from the VA to continue your work implementing the core elements in your outpatient settings. So now I'm going to introduce Dr. Sarah Kabani, who will speak to antibiotic use and stewardship in nursing homes. Dr. Kabani is an adult infectious disease physician in the Office of Antibiotic Stewardship Division of Healthcare Quality Promotion at the CDC, and her areas of concentration include older adult and long-term care antibiotic stewardship. Thanks for being here, Dr. Kabani. The floor is yours.
Thank you so much, Katie, and I want to thank everyone for joining us this afternoon as we talk about stewardship and antibiotic use. So over the next few minutes, I'm going to review some of what we've learned about antibiotic use in nursing homes. Those of you, and I see many of you here today that work in nursing homes have probably heard these numbers before, that around 50 to 70% of nursing home residents will be prescribed one or more courses of antibiotics a year, and 40 to 75% of that prescribing is inappropriate. And what we mean by it is, and not only sometimes the drug is not necessary, but there's opportunities to improve the choice of the drug, as Patrick highlighted in his presentation, the dose, the duration, or adjust the therapy. But a lot of this data that we have was based on very limited studies that were done in a few facilities. And those studies were done in a very few facilities, and so we've set out over the past year or two to understand antibiotic prescribing in this setting better. So one data source that we looked at was national pharmacy transaction data that reflects antibiotic use nationally in the nursing home population in 2014. And we found that there were over 14 million antibiotic transactions that were dispensed. And we don't use this number exactly to quantify data. As some of you who work in the nursing home know that sometimes you have multiple transactions per course. However, it is very useful for us to compare across settings and to compare in different ages. So 85% of those transactions were oral, and rates were higher in those below age 65, which likely reflects the short stay population. Fluoroquinolones accounted for 22% of all antibiotic transactions. And we found that the highest rate of antibiotic use, as you can see in this bar chart, was in the South Census region, which reflects some of the antibiotic use rates and geographic variations we've seen across the outpatient and the inpatient setting. And we've also used electronic health record data to look more closely at antibiotic use in over 1,900 nursing homes. And overall, we found that 50% of nursing home residents received an antibiotic in 2017. I've talked about fluoroquinolones in general in this previous slide, but levofloxacin specifically was the most commonly prescribed agent in this setting. And, this, Patrick and Catherine mentioned adverse events associated with antibiotic use, and specifically with fluoroquinolones. And the older adult population is the population that is at highest risk for some of those adverse events. Actually, in the recent FDA warning, elderly patients were specifically highlighted as risk for those adverse events. So this is a cause of concern. Urinary tract infection were the most common indication for prescribing, followed by respiratory, skin and soft tissue, and gastrointestinal infections. And you can see in this pie chart that almost 30% of those antibiotics were prescribed on admission to the nursing home, or around 46% were prescribed more than 30 days after admission. We've also done a prevalence survey, which is when we check antibiotic use in specific nursing homes on a single day. And 11% were found to be on antibiotics on a single day, but what we learned from this pilot prevalence survey that was done a few years ago was 23% of antibiotic use for prophylaxis. And that experience that we did in 9 nursing homes informed a larger prevalence survey that was conducted in 160 nursing homes to describe overall antibiotic use, and we hope to share this work with you soon. So this highlights an opportunity for improvement, which is testing and treatment for suspected urinary tract infections in nursing homes, because asymptomatic bacteriuria is really common in this setting. 15 to 35% of men, 25 to 50% of women, and all the residents who have a catheter have asymptomatic bacteriuria. We know that up to half of antibiotics that are prescribed for UTI in older adults are either unnecessary or inappropriate, as foul-smelling or cloudy urine frequently leads to unnecessary urine testing. This over-testing leads to overdiagnosis and treatment of asymptomatic bacteria with risk of adverse events and delays in diagnosis, because if you're treating an urine culture, you're missing what's really going on with this patient that's led to the changing condition. So now I'm going to shift and talk a little bit about the rationale for collaboration between hospitals and nursing homes. Patients are shared between acute care hospitals and nursing homes, and there's transfers of residents with multi-drug resistant organisms and C. difficile. There are already existing collaborations that can be leveraged for stewardship and for stewardship-related quality improvement initiatives, such as quality and safety efforts to decrease HAIs and multi-drug resistant organisms, and a focus on decreasing readmission rates. And there are some regional collaborations that are sponsored by state health departments. So what are potential activities that can be done? Nursing homes can leverage some of the expertise to identify and support stewardship activities. They can use some of the educational resources that hospitals have developed for their staff in the nursing home staff and residents and families, and coordinating post-discharge care. And this has been highlighted multiple times, and we've looked at this and seen this in the different analyses that we're doing, that there are critical gaps in communication between nursing homes, emergency departments, and acute care hospitals, and that antibiotic stewardship at discharge is very, very important. Communicating the important information around antibiotic use can help prevent readmissions and can help improve the treatment of infections. Standardized transfer forms can improve the communication of important information related to resident care. There was a recent study that looked at best practices of what a structured and timely summary should include that's sent to primary care providers from EDs. And I would argue that these are the same principles that should be communicated to a nursing home when you receive a resident who's on an antibiotic. You should clearly know the diagnosis, what medication changes were made, what are the results of relevant testing, and most importantly, what are pending diagnostic tests. Many times, cultures or C. diff results or other tests can turn positive after the patient was discharged. So for you to know what you need to follow up on is important. Of course, clear and detailed discharge instructions and contact information for additional questions. So we've looked at the implementation of antibiotic stewardship through the annual NHSN nursing home survey. Many of you from the QIOs are here on the line today, and when nursing homes enroll, they're filling this annual survey and answering some questions related to antibiotic stewardship. So we've looked at the 2016 survey to evaluate what are the baseline practices that are reported by facilities. And we recognize that these are variations because this is self-reported, but what this data really helps us identify is where the gaps exist. So 42% of the nursing homes reported implementing all 7 core elements. But most importantly, the lowest were reported for education, drug expertise, and reporting. And this really helps us in developing resources and to help support implementation in nursing homes. And also this data is very preliminary, but also this study suggests that nursing homes with higher staff hours dedicated to infection prevention and control were more likely to fulfill all 7 core elements. Which brings me to the recent educational resource or course that was developed by CDC in collaboration with CNS. And many of you have seen this course, and many of you have probably taken it. But this is a nursing home infection prevention and training course. It includes 23 modules with free education credits that covers the core activities of an effective infection prevention and control program, and goes over the recommended practices that decrease pathogen transmission, healthcare-associated infection, and antibiotic resistance. And it does include a module on antibiotic stewardship. We've learned from different settings, and Catherine shared some of the recent experiences from the outpatient setting, that antibiotic stewardship can improve outcomes and reduce infections with antibiotic-resistant bacteria and C. difficile. There was a Cochrane review of intervention to improve antibiotic prescribing for hospitalized patients, and an improvement in antibiotic prescribing was seen without a difference in mortality and a likely reduced length of stay. And it's also another systemic review and meta-analysis that includes 32 studies in hospitalized patients showed that antibiotic stewardship programs can reduce the incidence of infections and colonization with multi-drug resistant organisms and C. diff infections. And antibiotic stewardship implementation can also improve antibiotic prescribing in nursing homes. A systemic review of 14 studies assessing antibiotic stewardship programs in nursing homes revealed the following. 8 of those studies showed a decrease in overall or indication-specific antibiotic prescribing, and 10 studies reported improved guideline adherence. And what's the most important thing in this review is none of them reported a significant change in mortality or hospitalization, which highlights that we can safely implement stewardship to improve the treatment of infections. There is another study that implemented an infectious disease consultation to a 160-bed VA long-term care facility and showed a significant decline in rates of antibiotic use in C. difficile infections. We still need more studies to measure the effectiveness of core element implementation in improving antibiotic prescribing and in improving outcomes of residents. But the preliminary data we have and what we've learned over the last few years is very reassuring. I'm going to echo Catherine's comments about blocking your calendar for U.S. Antibiotic Awareness Week between November 18 and 24, and I'm happy to take questions at the end. Thank you so much.
Thank you so much, Dr. Kalani. Thanks for sharing that information about antibiotic use in nursing homes and opportunities for improvement. Our final speaker is Ariana Ocean. We'll just get the slides advanced in 1 second. Sorry, we're having a technical glitch. Sorry for the pause. Ariana, do you mind following me? There we go. I've got it. Sorry about that, everybody. Technical difficulties. I want to introduce you to our final speaker, Ariana Ocean. We'll be sharing information regarding the Pew Charitable Trust outpatient stewardship efforts. And Ms. Ocean is a senior associate on the Pew Charitable Antibiotic Resistance Project. Her work at Pew focuses on advancing research and policies to ensure the appropriate stewardship of antibiotics across healthcare settings. Thank you so much for being here, Ariana. The floor is yours.
Thank you, Kaylee, and good afternoon, everyone. As Kaylee shared, my name is Ariana Ocean, and I am a Senior Associate on the Antibiotic Resistance Project at the Pew Charitable Trust. I look forward to speaking with you all today about antibiotic stewardship policy. Next slide, please. Now, as you can see, we have a number of different items that we'll go over today. Specifically, we're going to learn more about the Pew Charitable Trust Antibiotic Resistance Project. We'll understand the role of policy in encouraging the implementation of antibiotic stewardship in healthcare settings. We'll describe current policies regarding antibiotic stewardship in inpatient and long-term care settings. We'll discuss the need for and also the barriers to implementation in outpatient settings. And then we'll highlight some approaches for encouraging the uptake of outpatient antibiotic stewardship. Next slide, please. Now, some of you might be wondering, who is Pew? So Pew is an independent, nonprofit, nonpartisan research and policy organization that aims to inform and improve public policy on a number of different issues. We work on topics that range from protecting the environment to reforming the prison system to addressing public health threats. Pew uses a variety of different tools to accomplish our goals, including research into policy solutions, partnerships with key stakeholder groups, provision of technical assistance, and advocacy to policymakers. Next slide, please. So Pew is engaged on the issue of antibiotic resistance for over 10 years now. Our current work is focused in three primary areas. The first is reducing inappropriate antibiotic use in human healthcare in both the inpatient and outpatient settings. The second is reducing the use of antibiotics in animal agriculture. And the third is spurring antibiotic innovation, which includes supporting the discovery of new antibiotics. Today I'll be talking about Pew's work to promote antibiotic stewardship in human healthcare, particularly within outpatient practices. Next slide, please. So antibiotic stewardship policies aim to promote and facilitate the uptake of antibiotic stewardship programs and activities across different healthcare settings. The goal is to reduce inappropriate antibiotic use, improve patient safety, and slow the emergence of resistance rates. Now, keep in mind that these policies can be enacted at various levels, from national level policies to state and local policies, and they can be driven by both government agencies as well as non-governmental organizations. Next slide, please. There's been significant progress made over the past several years about implementing policies aimed at spurring stewardship implementation, particularly in long-term care and inpatient settings. CMS, the Centers for Medicare and Medicaid Services, finalized a rule known as the Condition of Participation, which requires stewardship programs in long-term care facilities that participate in Medicare and Medicaid. This rule was originally scheduled to go into effect in November of 2017. However, CMS delayed the enforcement by an additional 18 months just to ensure adequate time for facilities to meet the requirements. The rule is now expected to go into effect for the end of this month, so May of 2019. In 2016, CMS proposed another condition of participation, which would require stewardship programs in hospitals. However, that rule has not yet been finalized. In addition, the Joint Commission, which accredits healthcare organizations and programs in the United States, including about 3/4 of U.S. hospitals, they implemented antibiotic stewardship policies over the last 2 years as well. In January of 2017, the Joint Commission included stewardship requirements in their accreditation surveys for acute care hospitals, critical access hospitals, and nursing care centers. In May of 2018, the Pew Charitable Trust and the Joint Commission, in partnership with the CDC and the American Hospital Association, hosted an expert panel convening to build consensus on the question of what defines meaningful antibiotic stewardship programs. These recommendations are intended to inform future efforts to reform stewardship standards in the healthcare settings that we just discussed. And most recently, in January of 2019, the Joint Commission proposed new antimicrobial stewardship requirements as a component of their ambulatory healthcare accreditation program. Next slide, please. Beyond these national stewardship policies that we just discussed, there have also been a few states that have issued requirements for hospital stewardship programs. Now, California was the first state to legally require acute care hospitals to implement antibiotic stewardship programs in their facilities. California first passed legislation back in 2006, which required hospitals to develop a process for evaluating the judicious use of antibiotics. And then they followed up in 2014 with legislation that added more specificity to the requirement. Missouri became the second state to require stewardship programs in acute care hospitals with legislation that was passed in 2016. This bill also required that facilities report their antibiotic use and antibiotic resistance data into the National Healthcare Safety Network, which is a surveillance system that's maintained by the CDC. The last example I'll give is Tennessee. So Tennessee has recently announced that reporting antibiotic use in acute care hospitals through the National Healthcare Safety Network Antibiotic Use and Resistance Module is going to be required beginning on January 1st of 2021. This is going to be a phased-in approach based on hospital bed size. Next slide, please. So while there has been a lot of success at implementing policies at both the national and the state levels that are aimed at spurring antibiotic stewardship implementation, these efforts have been largely focused on inpatient and long-term care settings. So there are a number of challenges when it comes to translating the success of these hospital stewardship efforts into the outpatient setting. As you can see within this graphic, we recognize that there are three main ways to ensure that hospital providers in inpatient settings prioritize antibiotic stewardship, even as they're dealing with a myriad of other public health issues. So these include incentives, which can include financial or regulatory incentives, measuring, which can include data feedback, especially as compared to peers, and technical expertise. That can include stewardship expertise. So in a hospital with a centralized organizational structure, hospitals are able to and often have resources to provide hospital policies, EHR, IT support, data analysis, and then expertise in infectious diseases, pharmacy, and quality improvement. All of these resources support all of the three different components: incentives, measuring, and technical expertise, which then in turn support the individual hospital providers in prioritizing stewardship. Now, that doesn't translate quite as neatly to the outpatient setting, which you'll see on the graphic on the right side. We recognize that there's a variability based on practice type. So right now we're going to focus on the average outpatient facility that is not part of a larger health system. So in this case, when we apply a similar construct of incentives, measuring, and technical expertise, to support outpatient providers in prioritizing antibiotic stewardship, it just becomes a little more complex. So whereas there's one organization that supports incentives, measuring, and technical expertise in an inpatient environment, there are many stakeholder organizations, as opposed to a single entity, that can provide support or conduct activities to achieve all of those three components, the incentives, measuring, and technical expertise, which would then support outpatient providers. So this makes it challenging to determine what organization will do what actions to support each of these three components in the non-health system affiliated outpatient setting. Next slide, please. So we believe that all of those three aspects that we just discussed, incentives, measuring, and technical expertise, are really important in driving outpatient stewardship implementation based on some of the research that we've done in the past. In November and December of 2017, PU conducted a total of 8 focus groups in 4 different cities within the United States. In each city, we conducted one focus group among internal medicine and family medicine physicians, and then one focus group among pediatricians. So some of the key takeaways. Most participants recognized that antibiotic resistance is an important public health issue. Yet many felt that it was less important to their daily practice when compared to other public health issues that they need to address in their patient populations. These might include obesity, diabetes, and opioid misuse. Participants agreed that inappropriate antibiotic use is a problem in outpatient medicine, but they placed responsibility for this inappropriate use on non-primary care settings, like urgent care, retail clinics, and on patient demand. Finally, when it came to antibiotic stewardship strategies, we found that participants in our focus groups favored education on antibiotic use, both aimed at patients and physicians, but were wary of tracking and reporting efforts. So addressing these perceptions and skepticism is going to be really integral to the development of effective stewardship policies. Next slide, please. Next, I'm going to walk you all through a few approaches that healthcare stakeholders are taking to help spur or facilitate outpatient stewardship implementation. When it comes to incentivizing stewardship uptake, there is the potential to integrate antibiotic stewardship policies within value-based programs. For example, antibiotic stewardship has been integrated into CMS's merit-based incentive payment system, otherwise known as CMS MIP, as both quality metrics and as approved quality improvement activity. So antibiotic quality measures are included as some of the performance metrics on which physicians can choose to be measured for the program. Additionally, antibiotic stewardship activities are included in the list of approved quality improvement activities that physicians can conduct in their practices to meet the quality improvement standards under MIP. Now, beyond CMS, some private and public payers have begun including antibiotic use measures as part of their physician quality scorecard program. Another approach, which was piloted in Arkansas, included antibiotic use as a quality measure in a cost-benefit and risk-sharing model for outpatient providers. One final example that I'll highlight right now is a pilot project that was implemented by the American Academy of Pediatrics in 2017 in partnership with an insurer and 6 pediatric practices within the state of Virginia. This project promoted the use of quality improvement methods to reduce antibiotic use for viral upper respiratory infections, improve antibiotic use for ear infections, and to better educate families within the practice. Physicians' participation in this project was incentivized by the insurer partner. It also qualified as Maintenance of Certification Part 4 for participating physicians. So, just to summarize, efforts such as those that I just described can help to incentivize outpatient practices to prioritize antibiotic stewardship implementation as part of ongoing quality improvement activities. Next slide, please. Now, measuring and providing feedback on antibiotic prescribing practices is a key aspect of antibiotic stewardship efforts in all healthcare settings. There are a number of validated antibiotic use metrics that are currently being used by healthcare stakeholders to assess antibiotic prescribing practices and to identify opportunities for improvement. So, for example, there are 2 antibiotic use measures within the National Committee for Quality Assurance, or NCQA's Healthcare Effectiveness Data and Information Set, HEDIS. One is focused on the avoidance of antibiotic treatment in adults with acute bronchitis. The other is focused on the appropriate treatment for children with upper respiratory infections. Now, NCQA recently proposed modifications to these measures for the 2020 measurement year, which would include expanding the age range for both measures to capture both pediatric and adult patients. As I previously mentioned, there are also antibiotic use measures within the CMS MIPS program that are used to assess quality of care. These measures include one measure that's aimed at assessing the avoidance of unnecessary antibiotic use for sinus infections, and one that's aimed at assessing whether the most appropriate antibiotics was used to treat sinus infections. Now, these individual, previously validated measures are important tools to measuring and providing feedback on outpatient antibiotic prescribing. So there's also the potential for creating a suite of measures that can provide more comprehensive feedback to providers about their antibiotic prescribing. During our focus group, participants expressed a fair amount of distrust around antibiotic use measures. For example, they believe that physicians could easily game the system by shifting their diagnostic coding to more antibiotic-appropriate conditions. So a suite of measures that looks at overall antibiotic prescribing rates, rates of prescribing for select conditions, and other elements of antibiotic prescribing could provide more motivating, actionable data to the physician. Now, the goal here is not to couple financial penalties or benefits to the suite of measures, but instead to provide more comprehensive and actionable data to the providers. Next slide, please. Now I want to take you through a few examples of how some healthcare stakeholders are using antibiotic use measurements to inform their stewardship efforts. So, the Utah Department of Health has utilized their state's all-payer claims database to analyze and then publish antibiotic prescribing rates for acute bronchitis by clinic. Similarly, the New York State Medicaid Office utilize their claims data to assess avoidable antibiotic prescribing rates for acute respiratory infections by county. So measurement efforts such as these can help to identify potential areas where stewardship efforts could be focused and also to provide important feedback to the providers. One other example of how healthcare stakeholders are using antibiotic use measurement to inform stewardship efforts can be seen in work undertaken by Aetna. So in 2017, Aetna implemented an audit and feedback effort where they provided physicians within their network with their antibiotic prescribing data. By analyzing their claims data, Aetna identified clinicians who prescribed antibiotics to at least 50% of patients with acute bronchitis. Then they sent letters to a select number of clinicians, which included CDC's guidance on antibiotic bronchitis management. Next slide, please. So, as I've previously mentioned, external healthcare stakeholders can play an important role in providing technical expertise and assistance around outpatient stewardship efforts. The CDC has also included outpatient antibiotic stewardship within their 618 initiative, which aims to bring together important healthcare stakeholders, such as Medicaid agencies and state health departments, to design and implement evidence-based initiatives to improve quality of care. One other example I'll share is the Illinois Department of Public Health Precious Drugs and Scary Bugs campaign. This campaign provides public commitment posters for participating physicians to display in their offices, pledging to prescribe antibiotics judiciously. This type of activity has been shown to be effective at reducing inappropriate prescribing. This campaign also offers educational webinars for physicians. Next slide, please. So, in summary, there really is a clear need to develop comprehensive policies to spur implementation of antibiotic stewardship in outpatient settings. However, this is going to require effort from a number of different healthcare stakeholders to incentivize stewardship efforts, to provide resource support around antibiotic use measurement, and also to provide technical assistance in the design and implementation of stewardship strategies. Future efforts should focus on how best to incentivize stewardship adoption and to better understand the roles of different healthcare stakeholders in addressing resource gaps. Next slide, please. So that brings us to the end of my slides. Thank you all again for your time, and I'd be happy to answer questions during our Q&A segment.
Thank you so much, Ariana. It's a really informative presentation. Thank you for being here. And at this time, we're going to go ahead and open it up for questions for all of our speakers. All of our speakers are available, so you can enter your questions in chat, or Kyle, can you let participants know how to get into the phone queue to ask a question?
All right, ladies and gentlemen, at this time, I would like to remind everyone, in order to ask a question, please press star then the number 1 on your telephone keypad. Again, the star then the number 1 on your telephone keypad. You will pause for a moment to compile the Q&A roster.
Okay, and while you do that, I'll turn it to Melanie to get to some of the questions in chat.
Thank you. We have several great questions that came into chat. There is a first question for Dr. Gee. So here's the question. One of the comments about the need for prophylactic antibiotics before dental care made me think that I need to review updated information on guidelines for that, and maybe others on the call can answer this as well. Perhaps our speakers could point us to the latest information on that. For example, is it still necessary for people with knee and hip replacements to take antibiotics before dental care? Is there information out there about, for example, what are the updated guidelines on prophylactic antibiotics before various kinds of care for various kinds of patients? Is that out there?
So this is Dr.
I know from my...
Go ahead, Patrick, please.
Oh, I was just saying, I know for myself, I get my information from my transplant team. Having a compromised immune system due to an organ transplant, they keep me abreast on any new information, especially with the use of antibiotics. Dental maintenance is a must due to me having diabetes and for the prolonged health of my new organ. So they let me know, any type of updates needed, but it is mandatory for me to be on antibiotics. Anytime that they do an excessive cleaning that may cause infections to my gum or any type of possibility for infection.
And this is Dr. Fleming-Dutra. I just wanted to, thank you so much, Patrick, for that response. And I just wanted to add that, a lot of these guidelines do come out from the professional societies such as ADA, the American Dental Association, as well as AHA for the prophylaxis of infective endocarditis with the American Heart Association, and from ADA and AAOS for the orthopedists, I believe that's their name. But I do want to point out, so please look to the National Clinical Practice Guidelines for the most up-to-date recommendations. I do want to point out that we at CDC have included some of those recommendations in our CDC training on antibiotic stewardship course. One of the modules there's a module on antibiotic stewardship considerations in dentistry, so that's a free available online training that you can use that has some of that updated guidance in, and I'm going to put the link right now into the chat box.
Great, thank you, both Patrick and Dr. Fleming-Dutra. Melanie, do we want to take one more in the chat, and then we'll check on the phone too?
There were two questions in chat about resources to help medical professionals, especially in long-term care facilities, to educate or push back on family members who are insisting on antibiotics for their family members. One person said, family often mistakenly believe they need to continue to advocate for antibiotics or their family member will not be receiving appropriate care. And it looks like current materials that are available that the person posing this question has seen appear to be unconvincing. And there was a second person who had similar comments about the need for resources to educate patients and families about antibiotic stewardship for long-term care.
Thank you so much for this question. And I agree. This is a difficult conversation to have, and it's a difficult mindset to shift because for years those families have been hearing from us as providers whenever something's wrong with their family member that this is probably urinary tract infection and some antibiotics will clear it right out. So for us to say that, we've now learned more and we know more and we believe that antibiotics should be prescribed when necessary to avoid any associated adverse events, it's a conversation to have, not when the resident is having a changing condition. It's a conversation to have early on admission and an ongoing education, and it's to be able to address those concerns and answer those questions. Regarding resources, CDC website has some resources, and HRQ website has resources for family education, and we are currently working on focus group and on developing additional education resources for families. Now, I do understand, as I said, this is a difficult conversation to have, and it's not something you do at one point in time. It's an ongoing discussion that you have with the residents and their families.
Thank you, Dr. Kabani.
I'll add some of those links to the chat box too for educational resources.
Okay, thank you. And I also would just put in a plug for the quality improvement organizations in your state are working with patient advisory teams on patient-facing resources and communication tools around antibiotic stewardship. So encourage you to, if you haven't already, work with your quality improvement organization, see if they have tools as well. And I'll check in with Kyle. Are there any questions in the phone queue?
We have one question coming from an anonymous line. Please state your first and last name. Your line is now open.
Hey, this is Coleman Customs in Alaska. Can you guys hear me?
Hi, Coleman. Yes, you can hear me.
So, I was going to say, based on the antibiotic prophylaxis, it was well answered from the physicians from the CDC, but it looks like the ADA, the Dental Association, updated their deadlines in 2014, and IDSA updated theirs in 2013, just from a quick search. But anyway, my question, so, antimicrobial stewardship programs have been very successful in the hospital, and before coming over to the QIO, I'm a clinical pharmacist. I led a pharmacy-led antimicrobial stewardship program for one of the large systems. But what we're looking at, and I guess this is more of a question for the physicians from the CDC, is how do we, without pharmacists being recognized as medical providers on a national level, how do we move the same type of systems in the hospital where I could, prescribe, de-escalate, order labs and all that based on our P&T committee, and even on discharge? Is there anything being looked at on a national level to allow clinical pharmacists to function in that level in the outpatient setting? Because, I really think that would fix a lot of our inappropriate prescribing if we had them doing the prescribing, especially in primary care type clinics.
Thanks for that question. So this is Dr. Clement at the CDC. I will say that sort of the scope of practice of different healthcare professionals is outside the jurisdiction, and CDC doesn't have jurisdiction over that, and outside of sort of the scope of CDC's work. I do want to point out, though, that we do, here at CDC, think that the role of all healthcare professionals are really important in antibiotic stewardship, and certainly want to acknowledge the very important role that pharmacists have played in hospital and outpatient and nursing home stewardship across the spectrum of healthcare as leaders of stewardship programs and really champions for stewardship. So really want to, unfortunately not all outpatient settings have ready access to a pharmacist that can assist them with outpatient stewardship, but for those who do, we would certainly encourage them to include pharmacists in their stewardship initiatives in the outpatient setting, and certainly I'll let Sarah speak to the nursing home.
Yeah, no, and I also wanted to add that consultant pharmacists play an integral role in antibiotic stewardship in nursing homes. They do look at antibiotics as part of their monthly medication reviews. There's been several quality improvement initiatives that integrated pharmacists, the consultant pharmacists, and providing education and providing feedback and improving prescribing practices in nursing homes that have been very successful. So as in hospitals and nursing homes, consultant pharmacists play a very, very important role in stewardship implementation as team partners and as leaders.
Great, thank you. Thanks for the question, Coleman. Are there any other questions in the phone queue, Kyle?
There are no questions at this time. You may continue.
Okay. And if anyone wants to get into the phone queue, press star 1. But we have several questions in chat still, so I'll go back to Melanie for additional chat questions.
Yeah. Another question is there any plan or discussion regarding a Joint Commission or CMS requirement for reporting into the CDC's National Healthcare Safety Network Antibiotic Use and Resistance module?
So this is Ariana Ocean, and that's a great question. I would say that, time will tell to see what exactly is going to happen. This is certainly something that folks are aware of and think is of high priority. So I know that's not necessarily a satisfying answer, but I think we'll have to wait to see what exactly happens.
Okay, thanks. Melanie, another question?
Yep. So a couple of questions to clarify elements of different presentations. So there's one question for Dr. Ocean about the focus groups that were held by Pew in 4 cities in the U.S. So you mentioned that those focus groups were discussing the challenges in getting providers to prioritize stewardship. And we did focus groups in 4 cities, and in each city there was one focus group among IM/FM physicians and one among pediatricians. And the question is, were the focus groups made up of only physicians? What about other outpatient providers' input?
Sure. I'd be happy to answer that. So within this particular study that we did, we had a total of 26 family medicine and internal medicine physicians, and then 26 pediatricians that participated. So we certainly understand and recognize the importance of all providers in stewardship, but this particular study was focused on the physician provider segment.
Great, and thank you. And there was another question for Dr. Kavani. One of the participants said, I'm not clear about what Dr. Kavani was saying about overordering of urine cultures in patients with cloudy or foul-smelling urine. Wouldn't those signs and symptoms be a good reason to order cultures?
No, thank you so much for this question, and I'm glad to have this opportunity to clarify. So cloudy and foul-smelling urine is more a sign of dehydration than urinary tract infection. If you look at criteria for diagnosing or suspecting urinary tract infection, and whatever criteria you end up looking at, whether it's acute dysuria or painful urination, urgency, frequency, suprapubic pain, blood in the urine, tenderness at the flanks, or worsening incontinence, cloudy and foul-smelling urine is not in any of those diagnostic criteria. It is a common misperception out there, so that's why I called it out, and it frequently leads to unnecessarily testing urine and overdiagnosis of infections, where you're actually just picking up asymptomatic bacteria, which is when you get a bacteria in a urine culture in an individual without signs and symptoms of urinary tract infection. So again, thank you for that opportunity to clarify. Cloudy and foul-smelling urine is more likely dehydration than it is urinary tract infection.
Thank you. Do you want to check on the phone line, Kaylee, or would you like more questions from the chat?
I think we'll do another in chat, and then we can check back in. Thank you.
Okay. So here's a question from both a comment and a question. So Margaret said, in our federally qualified health center, our CMO does quarterly audits on antibiotic stewardship to ensure our policies on specified illnesses, respiratory, sinus, UTI, etc. are being followed. Why don't more provider groups do this and share with their patients? As a clinician, I've had to tell my personal provider when an antibiotic he chooses is not the first line recommended by CDC for my illness. That is not how it should be. What requirements have health plans been doing with their physician groups related to showing best practices in their work?
So hi, this is Catherine Fleming-Dutra. So thank you so much for that comment, and I'm really excited to hear that your federally qualified health center is doing quarterly audits, and that aligns perfectly with the tracking and reporting core element in the core elements of outpatient antibiotic stewardship. That's exactly what we recommend, to perform audits and give feedback back to clinicians on their prescribing behaviors, because really data drives, knowing the data and giving that back to clinicians can drive behavior change. And is the foundation of delivering high-quality health care. As far as requirements to implement the core elements or to do audit and feedback, CDC doesn't have the jurisdiction to require this. We have put out in the core elements that we recommend this as a best practice, but that's what we can do. And I'm not aware of health plan requirements to do so, but the Aetna work is starting to, that Ariana highlighted, is one example of a health plan that is giving that feedback directly from the health plan to the providers. And we'd certainly like to encourage more health plans, health systems, and others to feed that information back to providers to help in improve antibiotic prescribing practices.
Thank you. Thanks for that question. Kyle, do we have anyone else in the phone queue?
Ladies and gentlemen, if you would like to ask a question, simply press star then the number 1 on your telephone keypad. Again, that's star then the number 1 on your telephone keypad.
Okay, we'll keep checking through the questions in chat, Melanie.
Okay, so this is a really interesting suggestion. Can we make it a requirement to have the indication included for all prescriptions for antimicrobials? Many pharmacists have no access to the details of a prescription as the indication is not required.
This is Kavani, and thank you for that question. I can speak to the nursing home setting that part of the new requirements that you have to have a clearly documented, indication with every antibiotic prescription. There's of course some challenges to that. Sometimes you start an antibiotic course empirically and then you find out more, but at least writing with the most likely diagnosis or what's the suspected infection would be very helpful. I don't think there are any such requirements in the outpatient setting, and that there is a challenge to that, but I do agree that having a clearly documented indication not only can help the pharmacist help with assessing appropriateness and providing appropriate education to the patient, but it also can help in retrospect when a clinic is reviewing their own data to evaluate for the appropriateness of prescribing.
Thank you. One more. Are there resources we can provide to our hospitals to assist them getting up and running with the AU module in NHSN? While everyone acknowledges this is a good idea in concept, it seems as though there's a barrier related to IT staff and resources.
Yes, thank you for that question. This is Catherine from CDC. I am not the NHSN antibiotic use expert, but I am happy to provide the link to the NHSN website. But I think that question is probably best directed to our NHSN team. So if those who need those resources want to either follow either Kaylee, who can get to us, or send us an email at antibioticuse@cdc.gov, we can connect them to the right team to get those resources.
I wonder if that's about if a module sometimes is designed for a learning management system and it's not always compatible with hospitals. So a system where some hospitals don't have a learning management system, sometimes there's a way to get the slides, that instead of having it in that format. So I don't know if that helps you to phrase your question for that team, but I'll offer that in case it does help. There are a few other comments and questions.
Okay.
Are there any, and I'm not sure if I have asked this one before, so I apologize if I already asked this. Are there any updates on the status of the CMS rule requiring hospital antibiotic stewardship programs?
So this is Ariana. To date, it has not yet been finalized. It is of high priority. For instance, the Presidential Advisory Council on Combating Antibiotic Resistance Bacteria in April sent a letter to Secretary Azar of the Department of Health and Human Services urging the immediate finalization of the proposed condition of participation rule in advance of the upcoming June of 2009 deadline. So, anything that, we don't necessarily know what's going to happen, and anything would be purely speculative. So that's what we know right now.
Okay, thank you. I think we have time for 2 more questions, Melanie.
That's perfect, because that is all the questions we've got. And
perfect.
And there are two clarification questions about clinical guidelines. The first one is, have recommendations for the duration of antibiotics changed, or is it still 10 days?
Thank you for that question. This is Catherine Fleming-Dutra. So this is a really important part of stewardship, is to use the minimum effective duration, so the shortest effective duration for the treatment of the illness. And duration recommendations really should, for the duration of therapy, that really is very dependent on the patient population as well as the infection that's being treated. And so that really should come from the National Clinical Practice Guidelines for that particular condition, such as those by the Infectious Diseases Society of America, IDSA, the American Academy of Pediatrics, AAP, or the American College of Physicians, whoever is issuing those recommendations for that particular condition. For many conditions, it is shorter than 10 days, and the historic 10-day duration is really just a duration of convenience. A lot of work has gone on recently to better define conditions that can be treated with much shorter durations, even 3, 5, or 7 days, being for many common infections. But again, that is very specific. The recommended duration is very specific to the infection and the patient population. So the key is to look to the National Clinical Practice Guidelines on the minimum effective duration for that condition.
Okay, thank you. And Melanie, did you say there was one more?
Yes, and more questions have come in, and they're really big questions about vision and so on. So we'll make sure that speakers get those questions, and maybe those can inspire you for your next presentation. So this is a really short one. Are there any metrics other than UTI, bronchitis, and sinusitis?
In the outpatient setting, there are maybe not as many metrics as we would like, but there are, and actually they asked Ariana to follow up on this after I get done. This is Dr. Fleming-Dutra. But those are the metrics that are available in the MIPS program, and you can actually search antibiotics. So if you go to the MIPS website and search the measures, you can search for antibiotics. There are a couple of additional measures that are related more towards inpatient conditions. But at least within that program, that's what we're limited to, were the measures that they've included in that list. I don't know, Ariana, if you want to follow up on that.
No, I think you answered that well. Thank you so much.
Okay, well, we are coming to the end of our session today, so I want to thank everyone for participating and thank the speakers for all of your information. If we do have any additional questions in the chat that we didn't get to, we'll work with the speakers to address those, compile them, and can post them where the slides and recording are available on the QIO program website. But again, thank you all for your participation. Before we close, I just want to put a plug in to save the date for our final National Learning in Action Network event on Wednesday, July 10th from 3 to 4:30 Eastern. During this event, you'll be hearing from CMS senior leaders and all about the QIO program outcomes and innovative strategies, along with strategies and actions for sustainability. So watch for more information about this event. It will be available on the QIOprogram.org website, and or your local Clean QIO will be providing information. So we hope you'll join us for that final LAN event. And I just want to thank everyone for coming and remind participants to please take a minute and fill out our post-event assessment following the call. When you exit the WebEx, you'll be able to access that post-event assessment. Again, thank you to our speakers, and I hope everyone has a wonderful afternoon.
This concludes today's conference call. You may now disconnect.